Hi everyone, my name is Shelby Hill and I'm a speech and language pathologist with 4 years of clinical experience in the field. I'm currently enrolled as a student at the Massachusetts General Hospital Institute of Health Professionals, where I'm pursuing my clinical doctorate in speech language pathology with a clinical focus on sign language disorders. I decided to continue my passion and my interest in sign language disorders after a really unique experience I had working with three culturally deaf adult stroke survivors who all had communication impairments as a result of a stroke in their first language of American Sign Language. What this looked like was evidence of paralysis and paresis in their dominant communicating hand, groping and stuttering of the articulators, which would be their fingers, in their dominant hand, evidence of synaphasia, right hemisphere disorder, pragmatics, and discourse deficits, all after a stroke. It was an extremely unique opportunity, and I'm super grateful that I got to see these different adults. I learned a couple things from this experience. One, sign language disorders exist. Two, as communication experts, I believe that the SLP has a really important role and responsibility to support the deaf community, which is a cultural and linguistic minority group. And three, if we are to treat these adults, we need competent training. We need education standards, which are severely lacking in our current practice guidelines and at our graduate training level. So I'm going to pose to you this scenario. I want you to pretend you referred a patient who is a deaf adult after their stroke. Maybe it's for communication. Maybe you're a hand therapist or a physical therapist. You meet your deaf adult patient for the first time. They show signs of what could be a sign stutter, groping, motor apraxia. Maybe you see that they're struggling to find the right sign to express what they're trying to say. Maybe you see discourse deficits. You probably didn't know that a signed communication disorder exists, because the fact is not many people do know that. Whether you did or didn't, do you feel prepared to assess this patient on their signed communication in terms of language expression and their receptive skills and their pragmatic skills? Probably not. And this is what led me to my clinical question. American Sign Language, the primary language of the deaf community, is the third most prevalent linguistic minority in the United States. SLPs provide assessment and treatment for a variety of linguistic and cultural minorities. However, many SLPs are unfamiliar how to provide cultural and linguistically sensitive care, assessment, and treatment for the deaf population due to the lack of these education standards and lack of clinical preparation. And the fact is also, the deaf community is growing, and it's pretty prevalent. People with hearing loss represent approximately 10% of the U.S. population, and most recent estimates of deaf Americans in the United States is approximately 100,000 to 1 million, but the exact number is not known because it hasn't been properly measured. Surface research findings suggest that there are approximately 5,000 deaf stroke survivors annually, and approximately 1,000 of those culturally deaf adults will have resulting sign aphasia, but not just aphasia. Right hemisphere disorder, sign stuttering, sign apraxia has also been mentioned in the literature. Some current solutions are to use an interpreter, and while an interpreter is an invaluable resource, they are not trained on the detection of impaired sign language either. Like other languages or patients who are bilingual, a trained professional is critically needed. And as therapists, we are bound by this ethical code to provide competent and sensitive care. The deaf community is a marginalized community. Statistically, they tend to have lower socioeconomic status, limited education, poor health literacy levels. They experience frequent language barriers, and this affects their socialization with the majority of other Americans. It affects their access to healthcare and preventative services. It affects their ability to be empowered citizens. Traditionally, deafness is viewed through the lens of a pathological disease. However, as communication experts, I believe it is our responsibility to protect the language access and equality for users of sign languages. The aging of deaf Americans is similar to the aging of hearing Americans in that there is a higher demand for care for deaf adults, and in order to improve these patient outcomes. So I propose two solutions. The first solution is possibly to create a survey to find out the experience and knowledge that practicing SLPs have regarding ASL and sign language, their opinions and attitudes about assessment and treatment of sign language disorders, their perceived level of preparedness, and their opinion on whether or not the SLP has a role with this population, and commentary on the clinical knowledge gap. Another solution is to address the learning-based knowledge gap and possibly propose an education standard framework for SLPs to improve their cultural and clinical competence when working with culturally deaf adults that use ASL as their first language or are bilingual communicators. I hope you enjoyed this elevator pitch. I'm excited to see what the future brings, and if you have any questions, please reach out to me. Thank you.